Perfect, perfect. Hey, everybody, good to see you and to have you here with us. Just going to give it 1 minute for the numbers to tick up here. All right, we do have a captioner again. So if you want to have captions, you can click on the closed caption button at the bottom to activate those for yourselves. And otherwise, as usual, we will have a video recording and the seminar slides available on our website. That usually takes a little while to download and upload. So we'll send out the email at some point next week to let you know when that's all ready and good to go. All right. Now, what do you think, John? Shall I jump in and get us going?
Yeah.
All right, let's do it. All right, so I will, on behalf of our steering committee here, and John and I in particular, I want to welcome you all to our seminar, which is going to be, it's our first one of presenting pilot studies that are funded by this project. This project is a NIDA-funded initiative to really work and advance the science on recovery community centers. And we do this, obviously, this monthly seminar series that you all are here for and have come to before. And beyond that, we do a scale repository to help people measure things, and we fund pilot studies. And this seminar, we are going to be showcasing the great teams who are doing the first studies within this series. And they'll be each, I'll be telling you who their topics are. So we go to the next slide. Let me see if we have it here, or we're doing something else first, Hazel. Oh, we'll get to that in a moment. Reminder, we are doing a nationwide survey of RCCs, which has come out from our discussions in the seminar series about the diversity of centers that exist and the different kinds of services that they provide and the different settings in which they're operating. And I wanted to give a shout out and a thank you to the many centers who have already completed the surveys. And you can see that our scale keeps going up because we keep hearing about more RCCs in the country. So we are making progress. It looks like less, but we really are making progress. If you are an RCC director and you have not gotten a survey link, please reach out to us so we can add you to it. And for those of you who have completed it, thank you so much. We use this kind of data to identify speakers, to think about themes, to think about issues, things you highlight. It's a really great way for us to know what you guys are thinking about and what you're doing. Next slide, please. Upcoming seminars, as always, we're going to be doing our seminars on the first Friday of a month. In January, we're going to be focusing on rural RCCs and unique challenges that they encounter and how they overcome them. And then in February, somewhat relatedly, we are then talking about telerecovery, and stay tuned for our March topic. Next slide. So what we're going to do now, as always, is our polling questions. This is to capture who is here, if you're actually engaging different stakeholder groups in the seminar series. So please take a moment to click through here. And then there's a thing on the side. So click it and then slide it down to get to all the questions. And the last question on this list should be something about today's topic. So I'm going to do that myself right now. Yeah, the question number 5 is to check all you apply related to today. All right, and while you're filling that out, Hazel, you can still advance my slide to the next one, right? So while you're filling that out and contemplating it, I just wanted to say that we have a total of 5 teams here with us today, and they will be presenting their projects. And one of them actually can't present today, so we can stretch our time a little bit more. Roxxanne, Newman, and Alexandra Collins are out sick today, but we will have the other 4. What we would like to do is have the teams present for about 5 minutes about their projects. And provide an overview of why they're doing what they're doing and exactly what they are planning on doing. And then we want to give 5 or a little bit more time to all of you to ask questions, make comments, make suggestions, give them feedback based on your expertise and experience that can help them make the best possible project. So we're really hoping to not just show you guys what's going on, but to hear back from you guys to make these projects even better. Next slide.
Is it okay if I share the poll results now before we move
right
forward?
after we are done? Actually,
Okay.
You know what? You can do it now because we get to see the polling question about the pilot studies. So
Okay.
why don't you go to that one next?
So it should be sharing the results. Oops, I don't know why it's annotating.
I don't see them yet. Here we go. So if you scroll all the way down to the pilot question. Oh, wait, I need to scroll myself. It's not what you can show, right? Everybody can scroll themselves. So question 5 was, what is the purpose of a pilot study? And all of you basically, are highlighting that it is to provide initial information. These are, small projects that are allowing us to, really start looking at a particular area, to get initial information, to figure out if the methods that you're using really work in the specific setting. It's to start. And the goal and the hope is that this project then leads to larger projects, new initiatives, new ideas down the road. So this is all building forward. And in that spirit, we have our pilot projects. And Hazel, you can advance the slides now. I'm only going to give an overview real quick of the 5 teams, and then I'll turn it over to Abby. So Abby Batchelder is going to start us off today. She's from Harvard Medical School, where the Recovery Research Institute is, and John and I are at. Her topic is examining sexual minority engagement in recovery community centers. Next, please. Next team is Bo Cleveland and Kyla Knapp from Pennsylvania State University. Their topic is understanding how recovery community centers impact their members' well-being, a pilot study using daily diary assessments. Next one. Next is our team here, Marc Johnigan, Marc McGuire, Sheila Speckter, and Marc Thomas. Marc Johnigan is from the Twin Cities Recovery Project, as is Marc McGuire, and Sheila and Marc are both from the University of Minnesota. And their topic is the impact of specific RCC programs and participation on recovery capital. Next one. This is a team who's currently not here, but we will sort of have information on them for you to peruse later. Roxxanne Newman and Alexandra Collins, both from the Brown School of Public Health, and their topic is an examination into the use of recovery community centers by persons on medications for opioid use disorder. And then last, we have Shelton Brown and Sarah Castedo de Martell from the University of Texas School of Public Health, and they will be presenting on preliminary development of a cost-effectiveness calculator for peer recovery support services and bystander naloxone distribution. And I wanted to give you guys this overview of the teams and of the titles to keep in mind sort of like the breadth of projects that await you. And we really hope for this to be interactive. So feel free to jump in with questions and ideas and suggestions. And with that, I would like to turn it over to Abby.
All right, wonderful. Well, I'm so pleased to be here. I'm going to go ahead and share my slides. And I am working with Jillian Shear, who's at the University of Syracuse, who I don't think could make it here today, but I will share the project. I have 2 screens. Can you see the slide?
Yes, we can.
Okay, great. So I'm just going to go over the project itself, and then I would love to hear thoughts and feedback about this work. So I'm going to be presenting on the project, as Bettina, Dr. Hopner said, examining sexual minority engagement in recovery community centers. And I am a clinical psychologist at Massachusetts General Hospital, an assistant professor at Harvard Medical School, and an investigator at the Fenway Institute, which is a community health center here in Boston that is really focused on serving sexual and gender minority folks. And through these roles, I have identified a need for better improving substance use treatment for sexual minority individuals. So briefly in this presentation, I'm going to go over a little bit of background related to the problem and what led me to this particular pilot, the pilot study that we will be completing with this support, and what it will hopefully lead to in terms of next steps. I'm going to just share the team who I'm working with on this, and then hopefully open the virtual floor to questions and comments about the project. So we know from the literature, just briefly, that sexual minority folks report more alcohol and other drug use than heterosexual folks. And sexual minority folks are defined as gay, lesbian, bisexual, queer identified, or other identified individuals who don't identify as heterosexuals. And while it's true that many people with substance use disorders don't engage in alcohol and other substance use disorders, even fewer sexual minority folks are engaging in treatment. And that's something that I've seen in the data at Fenway Community Health Center, and elsewhere. Recent findings from Dr. Kelly and Hopner, who everyone on this call knows well, I'm sure, let's see, I lost my slide, have identified that in recovery community centers in the Northeast, a higher than expected proportion identified as sexual minorities. And when I learned this, I was really interested, because going back to look at their data, over 20% of individuals who have participated in that previous work identified as sexual minorities, which is much higher than the general population, which is more like 4 to 5% of the population, which gave me pause and made me think, well, what is it about recovery community centers that may be helpful in better understanding and even addressing or improving existing treatment and recovery services for sexual minority folks? So that really led to this pilot application and now this project to better understand facilitators and ultimately barriers to engagement in substance use treatment and recovery services among sexual minority individuals. So really briefly, this project involves 2 aims. One is to do a deeper dive into the data that Dr. Kelly and Hopner, John Kelly and Bettina Hopner have already collected to better understand and characterize who has engaged in recovery community centers who identified as sexual minorities in the Northeast. And we'll look specifically at gay, lesbian, and bisexual identified individuals, as that's how the data is collected. And then we're going to do semi-structured qualitative interviews to try to better understand what is it about the services provided, the context that is the reason people are engaging in this source of support. So we'll selectively sample sexual minority folks with a range of primary substances used. So just really a little bit more detail, the secondary analysis, as I described, will both characterize the individuals who have engaged in recovery community centers in the past, but also examine some features of those individuals. So we'll look at demographic characteristics, like who are these individuals in terms of race, gender, ethnicity, education, income, what is their recovery status, are they in recovery, are they seeking recovery, types of substances used, recovery capital like employment and housing, and service utilization outside of recovery community centers. So this is all relatively novel information to the existing literature. We don't really know this right now. So this will be a real contribution to better understanding who's engaging in this type of service, and then to better understand the why and use that to refine existing intervention strategies and recovery support services. We're going to do these 30 or more qualitative interviews. So we'll do more interviews if we're not getting consistent results. So if we don't reach what we call thematic saturation, which is a way of saying, like, if we're not hearing the same thing over and over again, if we're hearing different things from different people, we're going to do more qualitative interviews to better understand why sexual minority folks are using recovery community centers at such high proportions. So again, we're going to selectively sample gay, lesbian, bisexual identified individuals with a range of primary substances to better understand who is using these and why. And we'll conduct these semi-structured qualitative interviews to understand facilitators, what's getting people to recovery community centers, what's the reason for engaging in these, and barriers, like what could be better, and what other services have people used or are they using and why in relation or in comparison to the recovery community centers. So the reason for doing this is really to better understand why we're seeing such high proportions of individuals who identify as sexual minorities using recovery community centers, and ultimately to use that information to inform future efforts to both treat substance use disorders and facilitate recovery support. As I mentioned, I've done some work looking at the data from a community health center specifically focused on sexual and gender minorities, and we are just not seeing engagement. People are not showing up to support programs, even though they are at elevated risk for substance use disorders, and those who do meet criteria are just not coming to the extent that they could. So I feel like this could be insightful. It could be eye-opening in terms of what do we need to do to better meet the needs of this underserved patient population. So the team, I am going to be working with Dr. Jillian Shear, who is a counseling psychologist with a background working with sexual minority women in particular, but also men in relation to alcohol use. And then John Kelly and Bettina Hopner as they had collected the original data that we'll be utilizing, and we're looking forward to working them and getting their feedback throughout the process as well. So those are my slides. That's the project. I'd love to hear questions, comments, feedback, ideas. I'm really excited to do this work. And I will stop sharing.
Perfect. Thank you so much, Abby. That was great. What kind of comments, questions, feedback do people have for Abby and her team? Anybody want to hazard a guess of why you think that RCCs are so much more successful and engaging?
I'm Thomasina Borkman. The surveys collect data on individuals, and it's very difficult to deal with networks. Your qualitative interviews would give you a chance to see if the sexual minorities, the larger number of them, they may be coming from other groups. In other words, not random individuals. So I would definitely ask questions about groups they might belong to for other purposes, advocacy groups or et cetera. I think that would be fascinating and a really good use of qualitative interviews.
Absolutely, I completely agree. I think that the other organizations and engagement, civic and otherwise, would be really interesting to know who are these individuals. Right. Absolutely.
I don't know how to unraise my hand. Oh, now, okay. Thank you.
Related question. So it seems like this study would generate hypotheses about why sexual minorities engage with RCCs, but you're curious about the preferential nature, and you want those lessons to apply for other kinds of programs as well. Yeah. So are you going to be assessing their facilitators and barriers for other non-RCC programs as part of this? And, yes. And also asking people who may have not participated in RCCs eventually, similar things about their perceptions of RCCs, if any, and programs.
Certainly. So thank you for those questions. I will definitely be asking about facilitators and barriers to other treatments. I'm very interested to know how many individuals who have engaged in RCCs have engaged in other things and why or why not. So that's definitely part of the qualitative interview guide. For this particular pilot, I won't be going outside the scope of sexual minority folks who have not engaged in RCCs. However, I am involved in various research projects at the Fenway Institute where we are thinking about that, certainly, and actively working on strategies to mitigate these barriers to existing substance use treatment and recovery support services for sexual minorities. So definitely working on that from a different angle, I would say, because I do hope to braid the results together ultimately. I think that seems like there may be something unique about RCCs that we can glean, whether it be a sense of community, whether it be the specific programming that may help us reduce this disparity really in access and engagement with substance use treatment and recovery support.
Thank you for your good work. And I hope you ask about programs not as enlightened as the Fenway Institute, because that's really
oh, I know. Yes, I know. Well, yes. I mean, if it's happening at Fenway, it's definitely happening elsewhere, right? So there's this model. Yeah, absolutely. So I'm working closely with a colleague, as I mentioned, at Syracuse. So she and I are asking questions in various kinds of settings because these are really nationwide problems. Absolutely, it's not specific to Boston, and it's not specific to the places that we're mentioning. Yeah. Thank you.
Great. So I'm going to take Elizabeth Burton's question, then I'm going to move us on to the next team. Elizabeth?
Certainly.
Thank you. And my question, it relates to some of the some of the comments that are going on in chat as well. It sounds like that the qualitative interviews are all going to be with participants and RCCs and not so much with staff. Is that accurate?
That is how it's written. If you're suggesting that we do staff and other key informants, I'm with you. I think that that is usually a great idea. And we might be able to adjust things a little bit. Is that where you're going?
Yeah, because I think that along your line of thinking that there may be structural or organizational reasons, and that's some of the hypotheses in the chat, if you will, around safe place and the like, that I think you may need to talk with staff as well as participants to get to some of those issues.
I love that, Elizabeth. Thank you for sharing that. I think that you're right on. And in other studies, larger studies, I usually build that in because I agree with you. I mean, these things are systemic. And if we think about stigma, like lower levels of stigma, it's not just coming from people who are attending, right? That's probably coming somewhat from top down and systems level things like staff. So thank you for that. I love that suggestion.
Perfect. And Abby, while we're going to the next person, be sure to check the chat. There's lots of great comments and ideas there. And then at the end of, after we're done with all the projects, we can go back to those questions.
Lovely. Thank you so much, everyone.
Yeah, this is great. Thank you, guys. The next team up is going to be Harrington-Bourg Cleveland and Kyla Knapp from Pennsylvania State University. And the slide is up. Go for it.
Okay. First of all, I just want to start by thanking the Recovery Research Institute, just not only for supporting this project, but just for their work in this area. I think it's such an important area, and just want to thank everyone there. So the title of our talk is Understanding How Recovery Community Centers Impact Members' Well-Being, and it's a pilot study using daily diary assessments. Next slide. This slide shows our research team. I just want to say I'm really grateful for working with this research team. We have a really broad range of experience. I've been working in developmental research and ecological momentary assessment, smartphone research for a long time. My collaborator, Tim Brick, is a phenomenal statistician and a huge expert on using technology for research. We have a great group of grad students who have phenomenal experience and skills, and also very fortunately have lived experience in the recovery space. And so we're really grateful. I think that the combination of skills and experiences we have here really helps us out a lot going forward. Next slide. So our group's approach to studying recovery is very specific. We're really trying to honor definitions of recovery that focus on recovery being very individualized and a very dynamic process. And a lot of it has to do with the daily maintenance of sustaining well-being as people encounter challenges and use social supports to get through their days. To do this, we use smartphones to gather intensive longitudinal data. That's also known as ecological momentary assessment or daily diary research approaches. And our goal is to understand how people maintain well-being by looking at their really dense data that they provide. This slide shows the Wear It emblem, which is Tim Brick's project, as well as what one of our survey pages looks like. It says, since awakening, how frequent have been your drug cravings? And we've done a good bit of drug craving work using this technology. Next slide. So our past work, I think, puts us in a pretty good position to do this current project. It includes work in both the treatment setting and recovery contexts. In the treatment setting, we work at the Cairn Treatment Facility in Pennsylvania. We did a project looking at emotional and physiological regulation during opioid dependence treatment, and we got really good data. We have 70% compliance. That used 12 days of data for 4 times a day. It seems like a lot of data to be entered, but during treatment, people do have time. Busy days, but you also you take advantage of the opportunity that they have being in a relatively controlled environment. We're doing another project looking at a drug that should reduce cravings for opioid use disorder, and this is in progress. In the recovery context, I started my work at Texas Tech University, where I worked with the amazing Kitty Harris, who's one of the major movers and shakers in the collegiate recovery space. And we did a project there with 21 days of data, only 1 assessment a day, but we get 90% compliance. And in that situation, we're very lucky because I basically hung out at the Collegiate Recovery Community Center for 2 years before I did this project. So, a lot of it was about building rapport and knowing the people that I was working with. And now we are doing a pilot in recovery residences, collaborating with the RAISE project here in central Pennsylvania. We are collecting data 3 times a day for both 10 days and 21 days, because this is going to provide us information on what people will sign up for, and also when this is perhaps too demanding. So those are our current projects, and I want to emphasize that a lot of this has to do with building rapport and working with the communities. So next slide, and then Kyler is going to take over.
Thank you, Bo. So today I will be talking with you about the current project that we'll be working on. So the goal of our project is to partner with Pennsylvania Recovery Community Centers to develop data instruments and data collection procedures that will allow us to assess the impact of RCCs on members' experiences on a day-by-day basis. Our target is going to be roughly 30 to 35 RCC members, as well as 10 to 20 participants who do not have current access to RCCs. And our design has 2 components. So the first component is a baseline survey, where we will be collecting information from our participants on things such as demographics, recovery histories, and so on. And then the second component is the smartphone data collection, where we will be deploying the Wear app that Bo just described on people's smartphones to assess things such as craving, mood, and people's experiences at the RCC as well as away from the RCC, with the goal here being to capture constructs that change more dynamically during recovery on a day-to-day basis. Next slide, please. So we are very grateful and excited to be partnering with 2 great recovery organizations that manage recovery community centers in Pennsylvania, the RAISE Project and Lost Dreams Awakening, or LDA. So the RAISE Project, they manage 2 RCCs, one in York and one in Lancaster counties in central Pennsylvania. And LDA is based in New Kensington, Pennsylvania. And both of these RCCs provide recovery support and trainings, and also support multiple pathways to recovery, including medically assisted treatment. So we're very excited to be partnering with these organizations for this project. Next slide, please. So the specific goals of our project, we have 3 specific goals. The first one is to develop our baseline and daily survey instruments specifically for this RCC context. So in many ways, this is our most substantial goal because, as Bo was talking about earlier, he and his lab have done quite a bit of work in the intensive longitudinal space. But as we know, all contexts are different. And so we know that it's very important for us to develop relationships and rapport with our recovery community center partners, their staff and their members. And to really leverage that expertise and work hand in hand with them to select the questions that we'll be asking and the ways we'll be asking them, and to really develop and hone our survey instruments to best fit this context and population. So that's our first goal. Our second goal is to, once we've developed these relationships and developed and honed our instruments, we will be collecting data and assessing its quality. So in this domain, once we've collected the data, we'll be doing things such as evaluating the response rate that we get to our surveys, our daily surveys, looking at the reliability of the instruments in our surveys, as well as testing potential associations in our data between things such as members' RCC experiences on a given day and their associations with well-being, for example, on that day. So our third and final goal is to determine the value of these assessments for RCC programming decisions. So essentially what this will entail is going back to the RCC, our RCC community partners, and sharing our findings with both the staff and the members, and gathering feedback from them on basically whether they find this information to be useful and how it might be leveraged to deliver insights on RCC programming and environments and such going forward. And I should note that at each of these stages, we will be compensating the staff as well as the members who participate and work with us at each kind of stage of the process. So next slide, please. So with that, thank you so much. And we really look forward to hearing your thoughts and questions.
Great, thank you so much, Kyla. What questions, comments, feedback do you have? We can also let it percolate a little bit and move on to the next team, and then you can also have a chance after the next two presentations to provide some further feedback. Marc?
I have one question, which is, do you have a plan to kind of roll out your tools for use in the wider community?
We would love to do that, and we have the capability of doing that. And you know, the big challenge that we're running into is recruitment, remote recruitment. Once we get people in the study, we are good to go. And we have some participants right now who are clipping along at about 80% compliance and doing a good job. The big challenge is that it's difficult to get the connection to the people who are working on the ground. We have wonderful partners and we've been working with the RAISE group in Pennsylvania. And when we, but then when, part of this is also COVID related. So we had to design this remotely. We want to do it remotely because we can blast it out everywhere. But at the same time, when we finally got to the recovery houses, some of the staff were like, yeah, I heard about this like 6 months ago, but I don't really know what this is about. So I started a tour of Pennsylvania where I drive to recovery houses with food and I get to know people. And a lot of it is just about building rapport, because why would they, you know, if I'm talking to people in recovery and I walk through the door, why would they provide their data and their effort? And so a lot of it is just building that relationship that very naturally happened when I was spending time with the recovery community at Texas Tech. I've done some work at the one at Penn State as well, but you know, it's a critical bit is actually building this rapport. And we've done work with homeless groups as well. And we're successful when we build rapport or when we have a program manager who's passionate about this stuff. And so that's really the very critical bit. So just passing out surveys and flyers won't work.
So true. Amazing that you're doing that, Bo. That's great. All right, I'm going to move us to the next team, but certainly put questions in the chat and ask them at the end of everything. Our next team is going to be Marc Johnigan, Marc McGuire, Sheila Speckter, and Marc Thomas, 3 Marcs in one team, who are presenting on the impact of specific RCC programs and participation on recovery capital. And I know Marc Johnigan rejoined Zoom. Are you back?
Is Marc here with us? Hopefully he's here.
Yeah, I'm here.
Okay, good.
Perfect. It's all you.
Yeah, yeah.
And you can
Marc
see the slide.
McGuire is as well.
Oh, good. Marc's here too. That we got 3 Marcs, 3 out of 3.
Perfect.
So I'm going to start. I'm Marc Thomas. I'm at the University of Minnesota. I'm a professor of neuroscience and director of the medical discovery team on addiction here in the medical school at the University of Minnesota. And I'm really, my role in this is really as a convener in this project, as my expertise is pretty far away from community research, but I'm excited to be involved in this project. I met Marc Johnigan, who's the president and CEO of the Twin Cities Recovery Project and the Dayton Recovery Project, about 2 years ago. And we struck up a friendship and a collaboration. And this is really the first funding that we've got. And we really have to thank you, Bettina and John and the RRI, for the funding you've given us for this project, which has as a goal really, Marc explained to me and really enlightened me about the power of the RCC model. It was really from him that I started learning about this, and I'm excited to be in this community and learn more from you all. So our goal in this project is really to try to move towards developing a set of best practices for RCCs in the African American community. And so this is a project that's a collaboration with the Twin Cities Recovery Project and our team at the University of Minnesota. It's a survey-based project that you'll hear more about at the end from Sheila. And I'd like to turn it over to Marc now to talk about his organization.
Yeah, how am I off? Yeah, I am. I'm off. Hello.
I can hear you.
Yeah, okay, great. Yeah, good morning. Thank you, Mr. John Kelly and Bettina, for this opportunity, as Marc stated. This is huge in regards to advancing the science on recovery community organizations and centers nationally, particularly to be able to advance science in regards to the African American community as well. Twin Cities Recovery Project is a multi-service agency that has a specific focus on African American community, right? And our goal has been to support individuals in their transition, right, from substance use, with a huge focus on harm reduction. And so our belief is that we don't wait on people or individuals to come to us, we go to them. So I have a team, street ambassador team that goes out twice a week to homeless encampments and high traffic areas. And I like to just use just real language and saying to show them love, right? To embrace them and to empower them. And so connecting them to the necessary resources that they may have, but also taking out clean needles, taking out naloxone kits, hygiene products, in the hopes of also connecting them to a peer recovery specialist that can continue supporting them and connect them to the necessary resources, whether that be inpatient, outpatient, medication assistant, treatment, or whatever types of treatment or services that they are in need of. And so you can go to the next slide. And so, as you can see here, our demographics, so the larger amount of the population that we serve are African Americans, even though we have an open door policy and we understand that substance use is not just an African American issue. So we service all individuals and make all individuals feel welcome. What I love about this type of work and what I've heard from so many participants is the fact that when they come in and they want to stay because of how they are embraced and how they are welcomed and how they are made not, to feel like they are worthy, right? And not dehumanized or stigmatized and all of those types of things, right? So have about 15 staff are individuals with lived experience, and I train heavily on servant leadership, right? So it starts, with this work, it has to start at the top and flow down, right? So I believe in, meeting individuals right where they're at, right? And leveraging the opportunity to be great throughout all of my staff, not just me. I share with them, we just have different roles, right? That's it. And so some of the services that we offer is one-on-one peer recovery coaching, GED prep, so connecting individuals to the opportunity to have access to getting the GED and supporting them through that process. We have our peer-to-peer development academy where we are training individuals on becoming peer recovery coaches. About 3 years ago, I applied with the state of Minnesota to be able to provide this service in the form of training, hiring, supervising peers, particularly to the African-American community. We saw huge disparities in who actually was receiving the training in the state of Minnesota, and pretty much because, you know, the training is not financially conducive to individuals who come from particular backgrounds, right? So we're able to train to offer that to individuals who meet a criteria for free. We also have a monthly alumni support group so that individuals who went through our training, they can come back and they can connect to other CPRSs and talk about the challenges that they may be having in even obtaining a job opportunity, or, you know, what challenges they're facing with working with individuals, and even talking about their own self-care, right? Today we're actually, and it's not on here, we're in partnership with Minnesota Department of Health, and we're having vaccinations here today, booster shots, testing, and that has been huge for our community because we host that here at our site. And, you know, there's been challenges from our community in regards to individuals getting the vaccination. So we've been able to support the community in advancing that. We have a community safety initiative in which I use interactive role playing to train individuals on how to be direct in moments of violence, how to delegate, how to distract in a moment of violence. And it's a participatory process, and the skits are developed through the individuals we're serving, so they're real life. Talked about the outreach, and we have HIV testing at both sites here bi-weekly for individuals, and giving them incentives for their participation, right, to participate in their own health and well-being. We can go to the next slide.
And Marc, just so that you know, you're at the 10-minute mark.
Oh, I'm at the 10-minute mark. Okay, we better move fast. So determining the impact, the focus of this.
Yeah, if you don't mind, can Sheila take this part, Marc?
You can.
Okay, yeah.
Thank you. Thank you. I'll just pop in here. And I know that we're kind of running short on time. So I am Sheila Speckter. I am an addiction psychiatrist at the University of Minnesota and have branched research into the community for the past several years, really. So I'm really pleased to be working with Marc Johnigan and the TCRP and Mark Thomas. And I am not a Marc. I'm the only one of the group that is not a Marc. So I just wanted to make note. Okay, so the advantages of this union, I would say, between the university and TCRP is we're able to, bring together our strengths and develop a way to really accurately or more specifically measure the impact and the effect of all of these services that are provided. Very unique. TCRP is so unique nationally. One of the other unique aspects of what we're doing is looking specifically at the Black population, and we know it here as elsewhere, the huge discrepancy there is in terms of outcomes, in terms of mortality rates, opiate use, and particularly notable here in our community. So that's where I think our project is particularly unique. We will be using some standardized measurements, such as the BARC or the Assessment of Recovery Capital, but also there are some more specific or short-term measures that we'll be using. that may be particular to our community, but not necessarily just here, such as, the impact of insurance. Also looking at, okay, so we know referral doesn't usually work. I mean, referral, just here, go do this, it does not work. So are these new strategies with these peer specialists, do this happen? Are there barriers in our community? I'm one of the providers for buprenorphine, for instance, and are people getting there? Are our participants actually getting where they need to go? And what are the other barriers that we're experiencing? So that's really the very nutshell version, and I'm really happy to be part of this whole project.
Thank you. Happy
Perfect,
to take any questions if there's time, but there may not be.
We technically don't have time. Can you stop share? I can see if there's a burning question of somebody having a hand
Absolutely.
raised.
Yeah, thank you.
Let me see. I don't see a burning question. Hopefully you'll still be able to ask after our final team presents.
Thanks
and
again
that
for the
team is going to be, and thank you. And for you guys for presenting and the overview. Next team is Shelton Brown and Sierra Castedo de Martell. And I'll let you take it away straight away.
Great. Thanks so much for having us. My name's Sierra Castedo de Martell. You want to introduce yourself?
Yes, Shelton Brown. First name's Henry, so some of my emails say Henry.
And we're going to talk to you about the our project, the preliminary development of a cost effectiveness calculator for peer recovery support services and bystander naloxone distribution. So let's start with kind of our ultimate goal and vision. We are working towards building out this big multifaceted calculator that will help community decision makers kind of figure out what would be best for their community, depending on their existing resources, what kind of infrastructure related to substance use they have in their town, and kind of figure out how to spend potential funding dollars that would come down in the future. And we are going to accomplish that by kind of breaking this project into smaller chunks. And the chunks that we're starting with are long-term peer recovery support services and recovery community centers and bystander naloxone distribution. Now, cost effectiveness is the method of economic evaluation that we're using to help decision makers. And you can kind of think about cost effectiveness as a little bit like the cost per ounce at the grocery store. But instead of cost per ounce, it's the cost of an intervention for every unit of health benefit that it gives you. So that might be an extra year of life expectancy, or it might be, quitting smoking or something like that. So you can kind of set whatever you want that health benefit to be, and it's a little complicated, but you add up all the costs and essentially end up with that result. So the cost per unit of health outcome. So to accomplish that, there's going to be some interventions that we'll have to totally start from scratch with. We'll have to do the initial economic evaluation, and we'll have to turn that evaluation into a calculator component. That's the case for long-term peer recovery support services in recovery community centers. Nobody else has done this yet, so we'll be doing that completely from scratch and then making it part of the calculator. For bystander naloxone distribution and a few other interventions, that aren't part of this pilot project, somebody else has already done that economic evaluation. So we're focusing on just turning it into a component of our cost effectiveness calculator. Now we'll be workshopping our analytic models, workshopping all of the calculator components with 2 local recovery community centers. And I want to give a huge thank you to Communities for Recovery and Recovery ATX. Those are the folks we'll be working with. I know I saw Bob on here. Bob is at Communities for Recovery. So we also want to share with you just a taste of projects that we've worked on in the past that use a similar calculator approach. Dr. Brown is going to start out. He's going to show you one that's not substance use related, and then I will show you one that's collegiate recovery related, but a little less pretty. All right, here, let's get out of this.
Right.
So we're going to pull up.
Right. So I'll just explain a little bit. This is this was something I did with Jim Salas and some people at the Active Living Center. in San Diego. And we basically wanted to make this is cost per met. Okay, so it's physical activity with schools. These are elementary kids. I think there's some analogies here. The RCCs are going to be different sizes. They're going to have different resources. So it's going to make sense, to do program A versus B, depending on like how the need and your resources,
participants, that kind of thing.
Yeah.
Yeah.
And so we did activity breaks, which is basically like kids getting up and moving about. We did recess, which everybody I think had. And then also PE. And I thought I would just show the example. Way I did this, or I should say we did this, was Andrew Springer and Allison Marshall. We basically wanted to make this so if you could, scale it to the school. So you put like 400 people in. We've got.
So I can only see the PowerPoint slide that says examples of classwork.
Here,
are you showing the calculator?
Thank you so much for letting us know that. Yes. Yeah. I thought we were sharing the whole screen. That is my bad.
It's this one.
Right. There we go. All right.
Thanks.
Can you see it now?
Oh, that looks much prettier.
Yeah. So it's kind of like, all right, so let me speed up here because it's we're running out of time. It's so that's the size of the school. We currently have 2 PE teachers. Cost effectiveness is incremental. It depends on what are you getting in, for extra resources added. So in this case, we're going to say they're doing 30 minutes. Let's say they have 30 kids. Let's say they are doing 2 days a week. They're going to hire a teacher. So we're going from 2 to 3. We're going to go to 45 minutes and, we're going to basically make it 25 students. Okay. Instead of 30. Okay. For the student pupil ratio. And we're going to do 3 days a week. So we're going to add a day a week. Okay. And, then we had some other things like, do you have indoor facilities? Do you have a gym, or do you have like good outdoor activities? Do you have an evidence-based program like Catch, okay, in place? And so basically it spits out a cost per pupil per week and a change in METs, and then the ICER, which is the cost per MET added. And so basically I kind of have a sort of hokey thermometer here. Higher is worse. Okay, so if you're here, that means that it's highly cost effective. If it's up here, maybe. Okay, if it's over here, beyond that to the right, then no.
Great, thank you. So this is a much more, this is really nice and polished. This is kind of the vibe of what we're going for. Something really simple to read. Sorry, go ahead.
No, I'm just going to say we're going to work with the same people on this project that they made it look pretty. My Excel spreadsheet was not very pretty.
And I have an example. And are you able to see the PowerPoint slide now? Okay, great. I see nods. So, and my kind of foray into this realm is a lot less pretty. It is Excel based. And you can actually go to this URL, collegiaterecovery.org/media. And you can play around with a substance related calculator yourself if you would like to. Unfortunately, the physical activity calculator we just looked at, that's housed on kind of an internal server right now, so you're not able to play around with that. But yeah, so just kind of gives you a view of what that'll look like. I'm not going to walk through the example though, just because we don't have time. I want to leave plenty of time for questions. Here's our contact info. I'll also copy it into the chat box. And I'm going to stop sharing screen and see if we have any questions or comments.
Perfect. Thank you so much, Shelton and Sierra. I will say the email that's going to go out next week with the registration for the next one and materials and so forth. We're going to include all the email addresses and names and presentation titles, because everybody on these teams said they would love to hear from you guys and be available for further conversation. So please do feel free to reach out beyond today's presentation to talk with them. All right, questions for Shelton and Sierra before I turn it over to Dr. Kelly. Akusa.
So I actually have a question for Marc, the previous presenter, if that's allowed.
Yes, which one of the Marcs? Go ahead.
Oh yeah, you're right. The amazing presentation that they gave. So I'm a Doctor of Public Health candidate, and for my thesis project, I'm conducting a qualitative study involving Black American clergy and finding out their views on harm reduction and how the Black American Church can intervene in the opioid crisis. And since part of your focus is on Black Americans, I was wondering if you have thought of involving the church and the clergy in the amazing program that you're doing. I mean, because I know that the Black American Church has a lot of social capital when it comes to the Black American community.
I think we may have lost Marc Johnigan, who you were probably directing that to. But as one of the other Marcs, I'll step in and mention that the other Marc, who you didn't hear from, is a bishop in a Black church, and we talked with him about about how we might try to do some studies on this as well. It's a great idea. We need to know more about that. It's such a powerful influence in the Black American community, and surely a source of relief for many in their struggles and addiction. And so we need to understand more about that too. We'd like to incorporate that, but we don't have a specific plan to do it yet. Thanks for your question.
I'll encourage you to, because what I'm hearing so far is very amazing. They really want to help in the situation. Thank you.
Great. Thank you. And with that, I'll turn it over to Dr. John Kelly for some closing comments.
Hey, can you hear me? Hey, everybody, fantastic. I'm thoroughly inspired by that set of presentations. I hope you all found it as interesting and inspiring as I did. It was just fabulous. What a tour de force across many different domains. We heard about examination of the impact of specific RCC programs on recovery capital. What we didn't hear today, which is one of the funded projects, unfortunately, the presenters were sick, but a qualitative study looking at medication use, understanding medication use within the context of RCCs. We've heard about the cost effectiveness study, the fantastic promise of that. Also, a pilot study using kind of more fine-grained temporal resolution of assessment, and then sexual minorities, again, looking at very important issues of inclusivity and diversity within the context of RCCs and recovery support services. I thought what was nice about this array of presentations today, and I'm going to be very quick here because we're running out of time, but was just the bandwidth in terms of the array of methods, that was included: qualitative, quantitative, mixtures of both of those, cost effectiveness, and the different kinds of assessment in terms of kind of what they call ecological momentary assessment, or the kind of capture, electronic capture, of more fine-grained temporal capture of behavior change. Also, kind of the questions that were addressed really covers the gamut, doesn't it, of the things that we're all interested in this really early stage of research on recovery support centers. That is to say, who engages with recovery support centers? How do people use them? What do they use? What do they get from participation, and how cost effective are they? These are all critical questions which were addressed by these team of fantastic investigators and projects. And then covering just the final thing I just mentioned is the thematic focus. Again, very important issues of stigma, discrimination, and inclusivity, particularly regarding medication use, which we know is stigmatized, and how that is addressed in the recovery community. We're finding very good preliminary data already of how positively viewed medication use is by recovery community staff and participants. That's really good news. And also, the overrepresentation of minority participants is another really good sign that these entities are really attracting and engaging and really open to all kinds of folks from, regardless of pathway, regardless of race, creed, color, etc., or sexual minority status. And then the look on domains of functioning in terms of recovery capital broadly writ, and also quality of life and self-esteem, happiness, these kinds of things, as well as the accrual of more standard things like housing, jobs, training. All of these things are captured and covered in these domains. So it really is just a nice mix for me. And I think it really impressed the reviewers on the board, our advisory board who were reviewing, including Bettina and myself, just really inspired by this set of presentations and projects. And I just can't wait for the data. I've eaten my lunch, but I'm hungry again for some for these projects to be done. And it was just really inspiring to see them all. Congratulations to everybody for getting these projects. And thank you all for applying. As Bettina often mentions, you know, we want to work with you. If you have projects and you're not quite sure about them, please reach out and you know, pitch an idea. We're happy to help you. You know, we want this to be a collaborative thing. The goal is to really get more research going. So if you have an idea and you're not quite sure what to do with it, pitch it to us and we can maybe help you brainstorm about how to plan it out. And we want to be on your side to get funded. So thank you for applying. Congratulations. And I'll turn it back to you, Bettina.
Wonderful. Thank you, John. And I just also wanted to add my huge thank you for you all for applying and conducting this research, and for everybody for coming here, sharing ideas, feedback. We have so many comments in the chat. We will be downloading the chat and reading through it and emailing it to you all. It is such a pleasure to be working with you all, with this amazing group of people on advancing the science and recovery community centers together. Thank you all very much. And I'm already looking forward to seeing you all in January again.